So, your textbook for neonatology doesn't quite go to, or maybe have all the information that is needed, okay? So you have to pay attention to my PowerPoint. Okay? Some of the objectives for the course is not in your textbook, okay? But after the introductory phase of the course, then it should be okay. But I put some chapters where you can make references to it if you need to. Okay? Or maybe you can call me if you have any questions. Okay?
Were we supposed to pick up a different book?
Huh?
Were we supposed to pick up another book?
Yeah, I think what happened is that the objective of the course was actually developed with the previous book. And then we have an updated version of the book. They changed the book. So they still haven't written the objectives for the course. But everything is still in line. Okay? It's just that your book doesn't have things in details like I would like you to. Okay? Yeah, but most of the stuff will be in the book. Okay? All right, so fertilization and implantation. You can find some of the information in chapters 1 and 2 of your book. So we're going to start off with fertilization, which is the union of a sperm cell and a mature ovum. The ovum is the egg from the female, and of course the sperm cell is from the male. So they unite together. Okay? And usually this occurs in the fallopian tube. Okay? Anytime this does not start in the fallopian tube, that what we call that is ectopic pregnancy, okay? Abnormal pregnancy. But the real pregnancy is in the fallopian tube. That's where the union of the sperm cell and the mature ovum, okay, takes place. After fertilization, the human body begins 40 weeks of growth and development. So a mother carries the baby for 40 weeks. I can't imagine any mother carrying it more than that. That would be too much labor there. Gestational age is 9 calendar months, consisting of 3 trimesters. Okay? The first 3 months, the second 3 months, and the third 3 months. So each trimester consists of 3 months. The fertilized egg or the fertilized ovum travels to the uterus for implantation. Okay, so the egg gets fertilized in the fallopian tube, and then it will head down to the uterus for implantation. So if the fertilized egg has not implanted, in essence, you can't really say that you're pregnant. Yeah. So it has to actually implant. Okay. Okay. So what happens now is, as the fertilized egg is traveling from the fallopian tube down to the uterus for implantation, there is a lot of cell division going on, okay? A lot of cell division of the mature, of the fertilized egg going on. So Here's the fertilized egg heading down towards the uterus for implantation. So now this cell here will divide into two, okay? And then these two cells, each one of them will divide again into two. And then this one here will divide again. So there is rapid cell division going on as the fertilized egg is going to the uterus for implantation. So the cells that are produced as a result of the rapid cell division are called the blastomeres. The blastomeres are the cells that form as a result of the rapid division of the matured, the fertilized egg as it's traveling from the fallopian tube down to the uterus. And each of the blastomeres is encased in a transparent tissue envelope. Transparent tissue envelope. Called the zona pellucida. So the zona pellucida is like the membrane, if you want to call it that encases each blastomere. So the cell division continues, okay? The cells will keep on multiplying, okay? As the fertilized egg is going down to the uterus for implantation. And all of a sudden, what you're going to see is that a lot of cells now have formed, okay? We have now a lot of cells as a result of the rapid cell division. And then those cells now will kind of come together and form like a ball. Okay, so you have something like this. Okay, like that. So those cells form like a ball. Okay? And then that ball is called the morula. The morula. It is at this point that the fertilized egg enters the uterus. It's at this point that the fertilized egg enters the uterus. So the next thing that happens then is that fluid will begin to form or build around the morula. Fluid around the morula. Okay? Now fluid forming around the morula. And a cavity will develop in the center of it. So you have fluid building around the morula, and a cavity forms at the center of the morula. At this point, the developing organism is called the blastocyst. Blastocyst. So when you have the fluid forming around the morula and a cavity forms on the center of it, it is called the blastocyst. Now, once gestational age has reached that period, the zona pellucida, which is the transparent tissue envelope for the blastomeres now will be replaced with a more effective membrane called the trophoblast. So the trophoblast, will replace the zonal pellucida once you get to the blastocyst level.
Can you repeat that?
Okay, yeah. So once the blastocyst has formed, which is technically when you have fluid building around the morula and the cavity forming at the center of it, then what you have now that will encase it is the trophoblast. So the trophoblast is a more effective membrane at this point, and it replaces the zonal pellucida. So now the next thing now that is going to happen is that fluid will begin to fill in the cavity. The fluid now will begin to fill up in the cavity formed at the center of the morula. You have fluid now getting in there. Okay? Any questions? So the next thing now that happens is that some of the cells in here kind of go something like that. Some of the cells inside the morula or blastocyst at this point will kind of build up at one end of it. Okay, it will kind of be like this, and then most of the cells will separate and kind of, plug up together. Okay, at one end. Okay, so now those cells that separated and are now at one end will form what we call the blastoderm, or the embryonic disc. So that is what is going to eventually form the baby. The blastoderm will give rise to the baby. And then the trophoblast will form the placenta, what we call the placenta. Now, placenta is the organ of respiration for the baby. The baby's lungs do not function in utero. Okay? The placenta is what is responsible for ventilating and oxygenating the baby's blood. And the placenta arises from the trophoblast, whereas the baby will form from the blastoderm. Any questions about that? Can I move forward? Brian, you got it?
I believe so.
Leah, you got it?
Yes, sir.
How about Rodriguez? You got it?
I think so, yes.
All right, okay, let's move on then. Okay, so this is where the blastocyst will attach or attaches to the endometrium. The endometrium is the outer lining of the uterus. Okay? So it attaches there with the trophoblast. And now you can see the baby there and begins to get nourishment. Begins to get nourishment. So the endometrium again is the outer lining of the uterus. Okay? One thing you're going to notice is after the baby has attached there, you will see the placenta begin to send like roots, just like a tree sending roots into the ground. Okay? begin to send the roots into the endometrium, so that the baby can get nourishment. Embryonic growth and development. We have 3 stages of development, from conception, when a woman gets pregnant, to the time that the baby is born. There are 3 development stages. The first stage is what we call the ovum stage. The ovum stage. Now, the ovum stage is from conception to implantation. From the time that the egg got fertilized in the fallopian tube until it implants in the uterus. That's the ovum stage. It takes about 12 to 14 days. From the time your egg is fertilized until the time it actually attaches to the uterus, about 12 to 14 days. And then after that, we go into the embryo stage. The embryo stage, which is from the from the end of the implantation, okay, until the end of the ovum stage, until the baby measures 3 cm from head to rump. Rump is kind of like tail. You see how the baby looks? It's like the baby's got a tail. Which one is in that way? Yeah, they start off looking like that. So from head to rump, okay? And that takes about 54 to 56 days, the embryo stage. Now, the baby is very vulnerable to exposure to drug, radiation, and infections. Baby is very vulnerable. It's like if you don't lose your baby in the embryo stage, then you're good. Once you get pregnant, if you don't lose it, then you're fine. So, during the embryo stage, if the baby is exposed to drugs, infections, and radiation, that can lead to congenital malformation of the organs. The organs will not form very well. The organs will not form very well. And then once the baby is born, they may have abnormal kidney, abnormal lung, abnormal liver, okay? So we have to make sure that during the embryo stage, the developing baby is not exposed to drugs, infections, or radiation, because that can lead to congenital malformation. And then after the embryo stage, we go into the fetal stage. The fetal stage is from the end of the embryo stage until the end of the pregnancy. During the fetal stage, most organs have formed, or most organ systems have formed. But if the baby is exposed to drugs or infections or radiation, at this stage, it can lead to abnormal functioning of the developed organs. So it's like the kidneys, develop well, but they don't function well. The lungs developed well, but they can't function well. Okay? So it will lead to abnormal functioning of the developed organs. Any questions? Now, gestational age refers to the time since conception. Gestational age refers to the time since conception. If you have been pregnant for 2 days, well, your gestational age is 2 days. If you have been pregnant for 2 months, gestational age is 2 months. If you have been pregnant for 39 weeks, gestational age is 39 weeks. So it refers to the time since conception. This is the way we divide the gestational age. A term baby is a baby that reached 40 weeks. They should stay there at least 40 weeks, unless something happens. So that's where we define term baby, 40 weeks. But babies can come 2 weeks earlier or 2 weeks later. So if a baby reaches 38 weeks before birth, we'll still call it a term baby, that's fine. If a baby reaches 42 weeks, well, we still call it a term baby. Okay, but what we really call a term is 40 weeks, but they can come 2 weeks before or 2 weeks after. Now, after 42 weeks, if the baby has not made any sign of trying to come out, the doctor may want to induce labor. Okay, because the longer the baby stays in there after 42 weeks, the more tendency for the baby to get in distress, because they grow very fast in the last trimester. They can outgrow the space in the sac. Therefore, they go into distress. And when they go into distress, usually what happens is that they're going to poop. They're not supposed to poop in utero. Babies are not supposed to poop, but when they go in distress, they poop. And then they will turn around and inspire the poop, which will then block their lungs. Baby's poop is called meconium. Meconium. That can cause problems during birth. Meconium. That's baby's poop. So we're going to induce labor if after 42 weeks the baby is not making any sign of coming out. Well, if they're less than 38 weeks, technically that's prematurity. Their lungs may not develop well. And if that happens, once the baby is born, the baby can have severe respiratory distress as a result of that. But now, if a baby is going to come out for some reason before 38 weeks, there are things that we can do to enhance lung maturity so that when the baby comes out, it will not have severe respiratory distress. We're going to talk about that. So I want you to understand here that after 42 weeks, they have a lot of problems. Before 38 weeks, they have problems. That's one of the things that we have to know about the baby in assessing the mother, because if we know that a baby is postterm, it's going to be postterm or preterm, then we'll be better prepared for the baby to come out. They may need CPR once they come out. Okay? Any questions about term, preterm, or postterm? developmental stages after birth. So we'll call them neonates from birth until the baby reaches 1 month. That would be a neonate. Okay? And then we'll call them infants when they are 1 month old until they are 1 year old. From 1 month to 1 year old, we'll call them infants. And then we'll call them a child when they are greater than 1 year old. Okay? So if you go in the NICU and call a baby a child, you'll be very wrong about that. Actually, the American Thoracic Society calls a child someone that has reached 8 years of age. So, but now, for the sake of this course, we're going to say 1 year or more. All right. All right, so now, like I said, excuse me, the blastodome forms the baby. We also call the blastodome the embryonic disc. Now, the embryonic disc is what is going to give rise to different body structures of the baby. Different body structures. So, the embryonic disc or the blastodome has 3 layers. It has 3 layers. So the slide is, this is the, well actually you can say, this is the ectodome. Next layer is the mesodome. And the innermost layer is the endodome. So again, the blastodome or the embryonic disc has 3 layers. Each layer will give rise to some body structures of the baby. So, the endodome, which is the innermost layer, gives rise to the respiratory tract. I want you to know that one. That's very important. I will ask you that either on your quiz or your test. That's one of the ones that you have to know. It gives rise to the epithelium of the digestive tract, the bladder, and the thyroid. It also gives rise to the primary tissue of the liver and the pancreas. And then you have the mesodome, which is the middle layer of the blastodome or the embryonic disc. It gives rise to the dermis, which is the inner layer of the skin, the dermis. The epidermis is the outer layer. The dermis is the inner layer of the skin. It gives rise to the muscles. It gives rise to bone, connective tissues, and the lymphoid tissues. It gives rise to the reproductive organs, and it gives rise to the cardiovascular system. That's very important. So I'm going to ask you which of the layers gives rise to the cardiovascular system. Because our profession is cardiopulmonary. Cardiopulmonary, so you have to know how the heart develops and how the respiratory system develops. So those are the 2 most important things that you need to know from the blastodome. The ectodome, which is the outermost layer, will give rise to the epidermis, the outermost layer of the skin. It gives rise to hair and nails, limbs of the eyes, central and peripheral nervous system, and skin glands. That's the entire baby there. Any questions? Please know which layer gives rise to the respiratory system and which layer gives rise to the cardiovascular system. Very important. Development of the pulmonary system. Now, the pulmonary system is one of the systems that begins to develop very early during gestation. So now you can see that the pulmonary system begins to develop 26 days after implantation. 26 days. And then it will continue to develop almost throughout the pediatric years. Throughout the pediatric years. We have millions of alveoli in our lungs. The alveoli are responsible for gas exchange. So because babies are still in the process of forming more alveoli, even after they are born, they are still forming it, is increasing in number, okay? Their gas exchange is not as perfect as ours. So for that reason, I want you to remember on your test, if a baby has a pH that is 7.30 or more, don't react to it. That will be fine. 7.30 will be normal pH for a baby. Okay? Because they haven't formed enough alveoli for gas exchange. Okay? So don't fix acidosis for a baby that is 7.30, 7.31, 7.3 is fine. There are 4 stages of lung development. We have the embryonic stage of lung development. During this stage, there is development of the trachea, the bronchi, pulmonary artery, vein, and the diaphragm. And then after that, we go into the pseudoglandular stage of lung development. So in this stage, you have more branching of the airways and development of the terminal bronchioles. Now, the terminal bronchioles are the last branches of the bronchi that give rise to the alveolus, the very last branches of the bronchi. Okay, so you have your bronchioles, and then you have your terminal bronchioles. Right, so the cilia also form in this stage here. The cilia are the hairy-looking structure on the wall of the trachea, like that. What they do is to beat, to move secretions to the upper airway. They are responsible for mucus clearance. Like when you give your patient albuterol, one of the things that albuterol can do, because albuterol promotes pulmonary hygiene, okay? It can cause the cilia to beat more effectively so that the patient can begin to cough and clear their airways of secretions, okay? And then after the pseudoglandular stage, we have the canalicular stage. Canalicular stage. That stage is characterized with the formation of capillaries, mainly capillaries. And then we have the last stage there, the circular and the alveolar period. And this is where the alveoli begin to form. Okay, like I said again, the alveoli formation will continue through the pediatric years before you get enough, and then the blood gas will begin to look like ours. So that brings us to something that we call the surface tension. Now, surface tension is a natural force that we have inside our lungs. Natural force that we have inside our lungs. Sometimes they call it the alveolar surface forces. So when they call it alveolar surface forces, they're trying to be funny. What they're talking about is surface tension. Everybody has got that force inside their lungs. And that surface tension has a lot to do with lung compliance. The surface tension tries to cause the alveoli to shrink at the end of exhalation. It pulls it together. Okay? So that means then that the less surface tension that you have inside your lungs, the higher your lung compliance will be. The more surface tension that you have inside your lungs, the lower your lung compliance will be. So surface tension is one of the things that determines lung compliance. It's actually two of them. The next thing is pulmonary fibers. The amount of fibers you have inside your lungs plus the surface tension inside your lungs are the two things that determine how your lung compliance will go. If you have more fibers inside your lungs, such as in pulmonary fibrosis, then you're going to have low lung compliance. If you have high surface tension, you're going to have low lung compliance, and vice versa. So now, this guy here, Laplace, Mr. Laplace, he's a French guy. He is a French guy, a French scientist. He came up with this law called the Laplace's law, and it is related to surface tension. So, what he is saying is that when the radius of a sphere decreases, goes from like this to this, if it decreases, surface tension increases. When the radius of a sphere decreases, the amount of surface tension in that sphere would increase. So, applying that to the alveolus now. You know the alveolus is like a balloon. During inspiration, it will open up. During exhalation, it will collapse back down. So that means then that during exhalation, the amount of surface tension around the alveoli will increase. And then if the amount of surface tension increases, that means that the lungs will tend to shrink some more. Not completely. Okay? So, I thank God that we have something that will prevent or fight off the surface tension. Otherwise, when you exhale out, instead of your lungs going from like this to this, you may go even smaller like that because you have that surface tension pulling on it. We have a chemical called surfactants. Surfactants. Surfactant is a chemical that our body makes that fights off the surface tension. So surfactant increases lung compliance. If it wasn't for surfactant, anytime we exhale out, our alveoli will completely collapse. So that during the next inspiration, it would take a tremendous amount of pressure to open them up. So that's what we have to keep in mind about babies, because a baby has to get up to like 35 weeks before they can have mature surfactants that can lower the surface tension so that their lungs don't collapse. Because if their lungs are collapsing, then they will have respiratory distress. Okay, so that's very important. Any baby that is born prematurely may not have the right amount of surfactants, which would then cause them to go into respiratory distress. Okay, so surface tension is inversely related to the radius of this sphere. So here is a surfactant here. Now, surfactant is produced by the alveoli type 2 cells. Alveoli type 2 cells. That's the cells that produce surfactants. It is present on the inside surface of the alveolus. Surfactant is present on the inside surface of the alveolus. So what happens then is when we are breathing in, the lungs are opening up. Surface tension is decreasing. Okay, once the lungs open up, surface tension decreases. And now when you begin to exhale out, surface tension will begin to increase and the thickness of surfactant around it increases, so that the lungs don't collapse, the lung unit don't collapse completely. Okay, so that's what the surfactant does. As the lungs open up, the thickness of the surfactant reduces. As the lungs close up, the thickness of the surfactant increases so that it can offset the surface tension. Functions of surfactants: it reduces surface tension and prevents the alveoli from collapsing completely, and that is true. If a baby is born prematurely and in respiratory distress, and we have them on mechanical ventilator, and their PERP is going through the roof, we don't want that, because what you got there is potential pneumothorax. What we can do then to improve compliance so that we can ventilate them with lower pressures is to give them surfactants. Okay? So by the way, if you're ventilating your baby on the ventilator, they should never use more than a PIP of 30. PEEP for babies should be less than or equal to 8. We'll not give them too much pressure. If you're going to use a pressure greater than that for a baby, you're better off giving them surfactants. So surfactant reduces opening pressure. Now, opening pressure is the amount of pressure that you need to open up the lungs. That's very easy. Your PIP. Okay, so if you have enough surfactants, your lung compliance will be higher, meaning that your lungs will be easier to stretch. And then the amount of pressure required to open it up will be lesser, and vice versa. Any questions? Okay, so 24th week of gestation is when the first type of surfactant begins to appear. 24th week of gestation. Now, surfactant has phospholipids in it. Phospholipids. It's got natural lipids, components, and then also it's got protein, but it's got more phospholipid than these other two. It's mainly phospholipid. Okay, it's like holding somebody's heart in your hands. You have almost all of the left heart, because you have left heart way bigger than the right heart. So, so when we talk about surfactant, basically we're talking about phospholipids because that's the predominant component of it. There are 3 types of phospholipids. The first one is phosphatidylcholine. Phosphatidylcholine. Now, this is the immature type of surfactants. Immature type of surfactants. It doesn't fight off surface tension very well. It is the first one to develop at about 24th week of gestation. So now you can think about it. If a baby, for some reason, is prematurely born before they get to 24 weeks or around 24, 25 or 26 weeks, the only type of surfactant that they will have is phosphatidylcholine, immature type of surfactant. That baby will be in a whole lot of respiratory distress due to surface tension. Now, phosphatidylcholine is also called lecithin. Lecithin is another name for it, immature type of surfactants. And then we have phosphatidylglycerol, PT. That is the mature type of surfactants, which is very good for surface tension. But that one there begins to appear at the 35th week of gestation. So a baby reaches 35 weeks, they're okay, because they have PG. They may not have a lot of respiratory distress. Now, there is another type of surfactants that the baby makes during gestational period, and the level of it in the amniotic fluid kind of remains constant throughout gestation, which is the sphingomyelin. So sphingomyelin is another type of surfactant that the baby makes very early in the gestational period, and then the concentration of it in the amniotic fluid remains constant throughout gestational period. So we have 3 types, okay? So how do we know that a baby's lungs are matured? Because that's one of the things that we have to determine before a baby is born. I mean, it's supposed to be that they get to 40 weeks their lungs should be mature unless the baby has some kind of problems in utero, like they have hypoxia. And the hypoxia can cause surfactant not to form very well. Acidosis can cause it. So, but now, if they don't have any of those problems, once they get to 40 weeks, you shouldn't have to worry about their lungs. So, but now let's say now that the baby is going to be born at 34 weeks, 35 weeks, 36 weeks. We have to do some tests to make sure that the baby's lungs are mature. The first thing that we can do is we can do what they call the LS ratio. LS ratio. So you draw the amniotic fluid. You are going to analyze the level of the phosphatidylcholine, which is lecithin. That's what the L stands for. To the level of this sphingomyelin, which is the other type of phospholipid that stays constant throughout your gestational period. If you have twice the amount of lecithin to the sphingomyelin in the amniotic fluid, then that would mean that the baby's lungs are mature. So normal LS ratio is 2 to 1. You have twice the amount of phosphatidylcholine, lecithin, to sphingomyelin. Any questions? That sounds like a test question. What's normal LS ratio? 2 to 1. This is not I to E ratio. I'm going to let you know that. Okay? All right, so the next thing that we can do to determine lung maturity is we can do what they call the lung profile. Lung profile. So what we do there is we are going to draw amniotic fluid. We are going to make sure that there is normal LS ratio, the level of the lecithin is more twice than the sphingomyelin, plus we have the mature type of surfactant in the amniotic fluid, which is the PG, phosphatidylglycerol. So if we have those two, normal LS ratio, we have PG, that is called lung profile. Lung profile. Now, lung profile is more effective in confirming the baby's lung maturity than the LS ratio or the PG by itself. Let me say that one more time. Lung profile is more effective in confirming the baby's lung maturity than the LS ratio or the PG by itself. So we're looking at two things here. Any questions? There is something called the shake or foam test. That's another way to determine whether the baby's lungs are mature. Okay? So the shake or the foam test, what they do is they will draw amniotic fluid into a test tube. And to that, they are going to add an organic alcohol, ethanol, to it. And then they're going to centrifuge. They spin it, centrifuge it. Spin it for 15 seconds, like that. And then they let it sit for 15 minutes. Now, if you have, after 15 minutes, if you have a ring of bubbles forming on top of the ethanol, like that, ring of bubbles, that would mean that the baby's lungs are mature. So that's the shake or the foam test. You take amniotic fluid, You add ethanol, organic alcohol to it, then you spin it for 15 seconds, and then allow it to sit for 15 minutes, and then you look for a ring of bubbles on top of it. So 3 ways that we can determine that. Any questions? I'll give you a break by 2:30, so let me get down further here. Okay, so like I said before, if a baby is threatening to come out before it is time, 40 weeks, and they must come out maybe because the baby has problem in there, or maybe the mother is not feeling well about the baby being in there, okay, we must get the baby out. Well, we can accelerate lung maturity. We can accelerate lung maturity, make their lungs mature quicker, okay? One of the things that we can do is we give the mother steroid, corticosteroid. Steroid will cross the placenta and then accelerate the baby's lung maturity. Okay? Now, babies born to diabetic mothers always have good lungs, you know, because they have all the sugar in there, you know, that matures their lungs very quickly. You know, like if you're diabetic, and then your baby is not up to 40 weeks, there's increased tendency that the baby's lung would have matured anyway. Okay? So steroid is one of the steroid in our body codes for glucose release in the body. The steroid makes the body to release glucose. Okay, so that's how come one of the side effects of taking steroid is hypoglycemia, high blood sugar, because you're constantly taking steroids. Another thing that we can do to accelerate lung maturity is inject the mother with thyroxine. Thyroid hormone. We can do estrogen or prolactin. The last two are hormones, female secondary sex characteristics, estrogen and prolactin. Okay? So these 4 things. Most of the time they do corticosteroid. Okay, they do corticosteroid for lung maturity. So here's the fetal lung fluid here. The fetal lungs secrete fluid. At term, a lung is filled up with about 20 to 30 milliliters per kg of fluid. A lot of lung fluid. The lung fluid is composed of protein. It's got bicarbonate. It's got sodium and chloride. What does the lung fluid do? Well, it keeps the airway patent. The airway, you know, fills everything up. The trachea, the alveoli, and it keeps it patent. Okay? It's technically collapsed. Okay? Even when you have fluid in your lungs are collapsed. Okay? We define that by the amount of air inside your lungs. If you don't have any air inside your lungs, they are collapsed. Okay? I remember when I was going through school, and they would tell me that somebody's lungs, you know, were collapsed. And then I'm looking for it to be that way. No, that's not what it means. What that means is that it doesn't have any air in it. Okay? So you have all this fluid filling up areas that air would have been in, okay, so that nothing happens to it. The lung fluid helps in the formation, size, and shape of the potential air spaces. It occupies everywhere that air will occupy. But now, after birth, all the lung fluid has to come out. Okay? The baby doesn't keep it and celebrate with it. It has to come out. How does it come out? So what happens is that when the baby is coming out, going through the birth canal, the vagina will squeeze its thorax, squeeze it. And then during that process, most of the lung fluid will exit through the baby's mouth. Whatever that is left will be absorbed once the baby begins spontaneous breathing. The rest of the fluid will be up, but most of it, I want to say like 85% of the lung fluid will be removed through the vagina squeezing on the baby's thorax during birth. If for some reason the baby does not get rid of all of the lung fluid, then the baby can develop what we call transient tachypnea of the newborn, which is that retaining the lung fluid. Transient tachypnea of the newborn. It kind of looks like pneumonia on chest X-ray. Okay, they still have a lot of lung fluid in there, and that can make their breathing very difficult. Their lung compliance will be low, their oxygenation will be poor, their ventilation will be poor. So the baby can go into respiratory distress as a result of retaining the lung fluid. Also, they call it RDS type 2, transient tachypnea of the newborn. So that means then that when a baby is born through C-section, right? Brian, have you ever watched a baby born through the C-section before? Yeah, they don't go through the vagina, do they? So that squeezing action is gone. There's no squeezing action to get rid of most of the lung fluid. So babies that are born through C-section have higher propensity of developing this condition here. They develop that transient tachypnea of the newborn because they retain a lot of lung fluid. Yeah.
I heard this recently, but I don't know. Sorry, I don't know much about C-sections, so I didn't know this. But I heard recently that babies born via C-section don't cry right away because of that, because of the lung fluid. Is that true?
The crying is different. Okay, there are three things that make a baby begin to cry. Okay, after they're born. The first thing is that inside the womb, it's kind of like warm in there. Okay, it's warm. There is a thermoregulation. So once they exit the birth canal, it's cooler, so that scares them. Okay, so oh my God, where am I now? Now, the next thing is that while the baby was in there, there was nobody touching them, and then all of a sudden you see everybody touching them. Oh my goodness! So that kind of scares them. Yeah, well, I don't think it has anything to do with that. Those two in particular, touching the baby and hearing the noise, gets them to cry. And they must cry, because if a baby doesn't cry when they come out, they're going to slap it. And if it doesn't cry, then we got a problem. The baby must cry. Crying of the baby is a sign of life. If they don't cry, we're in trouble. Okay? So everybody, anytime you go to the delivery room, and that first cry is always anxiously awaited. They have to cry. Okay? So any questions about hazards of lung fluid retention? You have transient tachypnea of the newborn, RDS type 2. I wonder if I should, yeah, let's go 15 more minutes and then we'll let me explain this, and then we can take a break. So, as you know, in the adult, the pressure, the blood pressure, like in us now, the blood pressure inside our left heart, or coming out from our left heart, is higher than the pressure on the right side of our heart. So what's normal blood pressure? Anybody?
120 over 80.
120 over 80, that's the one most people know. So this here is called the systemic blood pressure. It's on the left side. And then on the right side, we have another blood pressure. That's called the pulmonary blood pressure. That is 25 over 10. Pulmonary blood pressure is 25 over 10. Systemic blood pressure is 120 over 80, but that's the one that everybody knows. So now you can clearly now see that the amount of pressure inside our left heart is greater than the amount of pressure inside our right heart. But that is not the case with the baby. It's different, it's the other way around. The pressure inside their right heart is greater than the pressure inside their left heart. And there are two reasons for that. Two reasons. The first one is that oxygen doesn't go inside the baby's lungs in utero. The lungs are not the organ of respiration and oxygenation for the baby. The placenta is. There is no oxygenated blood flowing inside their lungs when the baby is inside the womb. You know, oxygen is a vasodilator. Oxygen is a vasodilator. Oxygen will open up your pulmonary blood vessels. Anytime you have hypoxemia, your pulmonary blood vessels will constrict. So that's what we have. Because we don't have any oxygenated blood flowing inside the baby's lungs, their pulmonary vessels don't get enough oxygen, so they remain constricted. Well, let me ask you this then. If I have two blood vessels, one is like this, and one is this way, which one do you think will have a higher pressure in it? The second one, right? Yeah, because if resistance increases, pressure increases. So now, so you have the pulmonary vessels constricting like that because there is no oxygen in them. Therefore, the pressure goes up on the right side. The pressure goes up. That's one of the reasons that you're going to see later why blood flows the way it does in the baby. It's different. Their circulation is different from ours. And that's one of the reasons why. The next thing is that the placenta offers low resistance to blood flow. Now, the placenta is a very big organ. You know, that's what we call the afterbirth, right? After a woman delivers the baby, the woman also has to deliver the placenta, right? It's a very big organ with millions of vessels, blood vessels in it. So blood that is coming back from the baby, okay, to the placenta does not meet resistance because it's got this. So it's coming from the baby's left side. There's a placenta down here, and you have all these vessels that the blood can branch into. So this blood coming from here doesn't meet a whole lot of resistance because it can go there, it can go there, it can go here, it can go there. As a result of that, the pressure inside their left heart is lower. Because the blood coming from their left will go to the placenta. It goes to the placenta to pick up oxygen. And then it branches into those millions of vessels. So that's what causes their left heart pressure to be lower than ours. And then oxygen causes their right heart's pressure to be higher than ours. So these two things are responsible for what we call the fetal circulation, the way that blood flows in the baby. Okay? The way that the blood flows in the baby. It's different. Now I'm going to do adult circulation, the way blood flows in us, so that when I start talking about the babies, you're going to see the difference. Because one of the things that a baby has to do after they are born is to transition to adult circulation. They make that transition. Because it takes hours. They do it gradually. Things have to change. Once you cut off that umbilical cord, it starts. You have to make complete transition to the way we circulate. So this is adult circulation. It is called extrauterine circulation outside the uterus once you're born. Okay, so I'm going to go over that very quickly. So this is ours here. Well, here is the right atrium, the left atrium, the right ventricle, the left ventricle. Okay, so now this is the superior vena cava, this is the inferior vena cava. And so all the little veins, okay, in the lower portion of the body will dump their blood, their venous blood inside this great vein. Yeah, we call it the great vein, the inferior vena cava. All the little veins on the upper portion of the body dump their blood into the superior vena cava, and then they empty into the right atrium. So there they go through the tricuspid valve, and then into the right ventricle, and then they go to the pulmonic valve, into the pulmonary artery, and then now it branches into two here, because we have two lungs. Then the blood goes into the lungs to pick up oxygen, okay? And now the oxygenated blood will return to the left side of the heart to the pulmonary vein. We have two of them, okay? And then finally they get into the left atrium, goes to the mitral valve or the bicuspid valve into the left ventricle, and then goes through the aorta, aortic valve into the aorta, right here, into the aorta, and then it goes all over the body, okay, to different arteries, organs, and up to the organs and tissues. They use up the oxygen, and then the deoxygenated blood now will return back through the different smaller veins until they make it back here. Okay, so the whole process continues again. So when we come back from break, you're going to find out that this is not what the baby's heart is doing in Europe. It is different. And we call that the fetal circulation. Fetal circulation. All right, so how many minutes should we take? 30 minutes? Maybe 40?
No.
All right. All right, let's do 15 minutes then. We're going to come back. Let's call it 15 minutes till. I'll give you 5 more minutes. 15 minutes till